Welcome to the afternoon session of MRI diagnosis of musculoskeletal disease. I'm Alex Merkel. I'm one of the moderators. I'm from University of Colorado. I'm a musculoskeletal radiologist there. The first talk will be on accelerated 1.2 minute 4 echo UTE based CT-like imaging using GC Sense and deep learning based denoising reconstruction.
Thank you for the introduction. I am an employee of Canon Medical System USA. Fast Pinnacle is a workhorse of MSK imaging because it's efficient and provides excellent soft tissue contrast. However, important MSK tissue like bone or tendon are invisible in FSC2D because their signals already decay at the time of acquisition. ZTE and UTE can be used for bone imaging, and there are several applications. For example, it can be used for bone fracture detection. As you can see in the middle, it's an MRI image compared to CT on the right. It can also be used for accurately quantify glenoid bone loss assessment for shoulder, as you can see on MRI image on the right and CT on the left. ZTE can image bone, however, important MSK tissue like tendon, ligament, meniscus are still invisible, both in CT and MRI. To fill the gap, we propose to use multiple echo UTE, where in combination with FSC2D, it can provide a comprehensive MSK imaging, which means it can image all type of MSK tissue. Here, example of ankle protocol. FSC2D provide conventional and excellent soft tissue contrast. Multiple echo UTE provide additional and complementary information for MSK imaging. For example, raw TE images provide tissue star weighting, which is important and sensitive to blood-related product. Multiple echo allow tissue star quantification. For example, in this case, it can perform tissue star map and produce tissue star for tendon as pointed by an arrow. For visualizing ultra-short tissue like tendon, in this case, we perform tissue TE subtraction to better visualizing tissue tendon. And finally, you can generate CT-like images. This is the 3D isotropic data, so we can reformat into any orientation angle as desired. Here's an example of 5 minutes 3D isotropic knee imaging, where arrow pointing to meniscus that are typically invisible in both CT and MRI until at later days of degeneration or damage. Why it's important to quantify tissue star? Because it can be used for evaluation of disease. In this case, you can see it can differentiate between overweight patient on the right compared to healthy control on the left. Furthermore, it has been shown that increase in tissue star correlated with disease severity. In this case, for example, is meniscus degeneration. So one area of interest is we would like to ask a question if MRI only for bone and soft tissue assessment. Because this can reduce cost and logistic and also eliminate radiation exposure, particularly for pediatric or patient require multiple CT assessment. UTE and ZTE can be a potential candidate. However, current limitation is low resolution and long scan time. Our goal of this project is to accelerate multiple echo UTE using conjugate gradient sense and combination with deep learning denoising reconstruction. In this study, we used the reference 5.8 minutes protocol with 4 echo. The sequence was scanned on 1 volunteer and 4 patients prior to surgery on Canon MRI scanner. The data then retrospectively undersampled from factor 2 to 5. Reconstruction was performed with both grading and CZ-SEN and combination with deep learning reconstruction denoising. We call it DOR for short. For quality image assessment, we use full width at half maximum and relative edge sharpness. As we can see, with the undersample radio data, we have a classic streaking artifact and also loss in resolution. With CZ-SEN, we can mitigate the artifact, allow faster radio imaging. In addition to CZ-SENs, we applied deep learning denoising on top of that to further improve SNR and image quality. Here an example from a patient. Top row, you can see grading reconstruction with different acceleration factor. At the bottom row is the deep learning reconstruction and CZ-SEN. The arrow pointing to the bone lesion, which is confirmed by CT at the bottom. As you can see on the top row, the pathology gets blurred out as we reduce scan time. However, it relatively maintains up to 1.2 minutes at the bottom. This is an example of other images where arrow pointing to the anatomical detail is blurred out on the top row on grading reconstruction, but relatively maintained at the bottom with deep learning reconstruction. To quantify image quality in terms of resolution and sharpness, we draw a light profile on the cortical bone. Here are example of light profile of the grading reconstruction. Compared to 5.8 minutes scan time, we see that the light profile gets broadened, meaning loss in resolution and sharpness. On the right is CZ-SEN and deep learning compared with 5.8 reference scan time. Grading reconstruction, the light profile are relatively maintained. So to quantify full width at half maximum, we can see that deep learning reconstruction has narrower full width at half maximum, which means that it's retained higher resolution compared to grading counterpart. On average, on all of the subjects participated, we do see 24% narrowing full width at half maximum with DLR compared to grading counterpart. More importantly, 1.2 minute scan with deep learning has similar full width at half maximum with 5.8 grading reconstruction. To quantify the image sharpness, we use relative edge sharpness. We started from the light profile. We compute the gradient of the light profile and determine the peak amplitude of the gradient. Relative edge sharpness is defined as ratio between peak amplitude. And as you can see that the higher peak amplitude means higher sharpness. And in this case, we see that 1.8 times sharper from deep learning compared to grading counterpart. On average, on all patient and subject, we do see around 2.3 times sharper images with deep learning and CZ-SEN compared to grading counterpart. And again, more importantly, we do see that 1.2 minutes deep learning with CZ-SEN allows similar or better relative edge sharpness compared to 5.8 grading reconstruction reference scan. So in conclusion, this study demonstrates the feasibility of less than 2 minutes 3D isotropic for echo using deep learning and CZ-SEN allow image quality similar to around 5.8 minutes grading reconstruction. In combination with FSC2D, it may enable around 10 to 12 minutes one-stop shop comprehensive MSK imaging. When appropriate, it reduces cost, logistics, and also eliminate radiation exposure, particularly for pediatric patients or patients require multiple CT assessment. Future work will evaluate the technique on the larger patient cohort, implement automatic segmentation, and the next step is to further improve resolution and sharpness using deep learning-based super resolution. With that, I would like to thank you for your attention.